Welcome to iPEMS, a podcast series that teaches about pediatric emergency medication safety and equips providers with strategies for quality improvement. I am your host, Dr. Tiffani Johnson of the Emergency Medical Services for Children National Resource Center. In this podcast, I will provide an overview of healthcare quality. In 1999 and 2000, the Institute of Medicine released two landmark reports that brought increased attention to patient safety and made recommendations for improvement. The first report, To Err is Human, helped increase awareness of the fact that healthcare in the U.S. is not as safe as it should be. The report defined quality in healthcare as the degree to which health services for individuals and populations increases the likelihood of desired outcomes and are consistent with current professional knowledge. The second report, Crossing the Quality Chasm, proposed 6 specific aims for improving healthcare quality. I like to use the mnemonic STEEP, S-T-E-E-P, to remember these aims. The S stands for SAFE. Recall that the IOM Committee on Quality Healthcare in America defines patient safety as freedom from accidental or preventable injuries produced by medical care. You may remember from previous podcasts that patient safety is particularly challenging in the emergency department due to overcrowding, the hectic environment, frequent workflow interruptions, multiple handoffs, and provider fatigue. Dosing calculations make pediatric medication in the emergency setting particularly error-prone. To reduce unintended harm from medication use, remember the 5 R's. Calculate the right dose of the right drug and give it to the right patient at the right time using the right route. The T in our STEEP mnemonic stands for timely health care with rapid identification and treatment. The goal is to avoid delays that can potentially be harmful to the patient. If a sickle cell patient presents with a vaso-occlusive crisis, managing his or her pain with appropriate analgesia in a timely manner is a critical component of quality care for that patient. Unfortunately, the nationwide problem of ED overcrowding sometimes hinders our ability to provide timely services, affecting the quality of care that the system is able to provide. Next come the 3 E's, effective, efficient, and equitable. Effective healthcare means that we are providing services that are consistent with best practices and are evidence-based. I'm sure you've seen great variability in the way different attending physicians practice medicine in your emergency department. The limited evidence to guide practice, physicians rely on their past experiences and clinical judgment, which will vary from one provider to the next. We need more research in the field of pediatric emergency medicine to allow for evidence-based practice, establish standards of care, and deliver more effective health care. Effective healthcare also involves avoiding overuse of resources, such as performing a test that is not likely to benefit the patient, as well as avoiding underuse of resources, such as not performing a procedure that would improve the patient's outcome. For example, a recently published study by the Pediatric Emergency Care Applied Research Network, also known as PECARN, developed and validated clinical prediction rules which can be used to identify children at very low risk of clinically important traumatic brain injuries. These rules can help guide the use of CT after blunt head trauma. Research such as this helps us deliver healthcare more effectively. Efficient healthcare means avoiding overtreatment and other unnecessary use of resources. These resources include tests, equipment, and supplies. An example of inefficiency in the emergency department is when a diagnostic test is repeated because previous providers don't have access to the patient's medical record. Many emergency departments around the country became more efficient in the use of limited healthcare resources during the recent H1N1 influenza pandemic. When the first wave of the illness hit, most providers were testing all patients with influenza-like illness and treating all infected patients with antivirals. Before long, critical resources were becoming depleted and ED providers had to be more efficient. They began to target testing to hospitalized and high-risk patients and to treat only patients that were considered high risk for complications. By avoiding overtreatment of patients who may not benefit greatly from antivirals, there were more supplies available for those who really needed it. Equitable means that the quality of healthcare does not vary based on race, gender, geographic location, or socioeconomic status. Although there is limited evidence in the literature looking at the equity of pediatric emergency care, healthcare disparities do exist in the United States, even in the 21st century. This was demonstrated in a national study published in Pediatrics in 2004 that found racial and ethnic disparities in wait times for pediatric patients treated in emergency departments. The reality is that patients with the same condition do not always receive the same level of care in the ED. Have you ever had someone ask you to expedite care or provide special services for the child of a physician? When we provide equitable care, we treat all of our patients as if they are VIPs and avoid giving preferential treatment. Strive for high-quality health care for every patient you see, whether they are the son of a welfare recipient or the son of a well-off physician. Try to increase your awareness about your personal biases and avoid letting them influence the care decisions that you make, such as the timing of services, prescription choices, or your prioritization for admission or bed assignments. Finally, the P stands for patient-centered. While evidence-based medicine is important, we must also be sure to customize our care to meet the needs of each patient. This includes considering the risks and benefits of an intervention to the individual child based on his or her age, comorbidities, allergies, and current medications. Failure to take these things into consideration can lead to medication errors, such as an allergic reaction or a drug-drug interaction. Patient-centered care also takes into consideration the values and preferences of our patients and their families. A parent may be more likely to follow discharge instructions and administer prescribed medications at home if you provide family-centered care that respects their values. Thank you for listening to this episode of iPEMS to increase your understanding of what quality in healthcare means. I hope that you will apply the STEEP principles to your clinical practice and strive to deliver healthcare that is safe, timely, effective, efficient, equitable, and patient-centered. In other episodes in the iPEMS series, you will learn how to apply these aims to improve the quality of medication use for children in the emergency department through various quality improvement methods. To learn more about medication safety in the pediatric emergency medical setting and strategies for improvement, please listen to other podcasts in the iPEMS series.
The iPEMS series is a production of the Emergency Medical Services for Children National Resource Center in partnership with the Alliance for Pediatric Emergency Medication Safety.